All right, we move on now to the respiratory system. And this system is really a partner with the cardiovascular system, if you think about it, because the job of the cardiovascular system is to deliver oxygenated blood to the body and deoxygenated blood to the lungs. So the lungs is responsible for oxygenating the blood, right? And that carbon dioxide that's released as a result of metabolism from the tissue cells is diffused to the blood, and that has to leave through the respiratory system, through the lungs. So we blow off carbon dioxide and we take in oxygen through the very important organs of the lungs. So when we look at the term respiration, we talked about cellular respiration. That's where we use glucose and oxygen, right, to make ATP. So respiration at the level of the lungs has some terms related to that we don't want to confuse with cellular respiration. So when you look at functions of the respiratory system, gas exchange is huge to this system because we're, again, taking in oxygen, getting rid of carbon dioxide. So that happens by diffusion. Remember that gases like carbon dioxide and oxygen can just diffuse across the plasma membrane. They don't need a carrier. They don't need any kind of protein. They just go from high to low. So it's very quick and efficient because the tissue cells that make up the lungs is what? You learn that in the lab portion. What is the tissue type that makes up the alveoli? Yeah, simple squamous epithelium, thin, flattened cells, one layer for quick diffusion from those air sacs, those alveoli, into the capillaries. And capillaries, when you studied the lab on blood vessels, what are capillaries made out of? Or even lecture, we talked about what the capillaries are made out of. Simple squamous epithelium again, yeah. So quick diffusion, just two thin cells to cross in order for oxygen, carbon dioxide to get to where they need to go. So gas exchange, hugely important. Regulating blood pH. The amount of carbon dioxide in our blood determines, that's one of the things that determines blood pH. There are others, but carbon dioxide is a big one because carbon dioxide is converted to carbonic acid, and we'll learn about that at the end of the class a little bit, but we'll get more into that in advanced A&P. But just know that CO2 makes acid. Carbon dioxide is converted to an acidic molecule compound called carbonic acid. So the more carbon dioxide that is trapped in the blood, the more acid in the blood, and pH is going to go what direction? Down. Yeah, low pH is acid. So we're going to drop less than 7.35 if we have what we call acidosis. So really, really important. If a person has bad lungs, COPD, like I showed you those lungs, or maybe you've know someone with COPD, their biggest problem is exhaling because their lungs are large and blown out because the alveoli are damaged and they're gone, so there's nothing to decrease the size of the lung. There's nothing to contract. And it's not really contracting, it's just relaxing and going back to its normal size. But they can't blow off carbon dioxide, so that builds up on their blood. And when the blood becomes acidic, enzymes in the nervous system can't function. And when enzyme in the nervous system can't function, people act really tired, really sleepy, non-responsive. And that's the things we think about when we come into a patient room and I see a patient that's normally like a chatty Cathy, and this happened to me one time. I came in, it was a man with advanced lung disease, and he was on a ventilator, but he could normally, talk and, get by. He just needed the assistance of the ventilator. But he was sitting there, his breakfast tray was in front of him, and he was asleep, sitting in the chair. Well, that's odd. So I tried to wake him up, and he's still unresponsive. Finally woke him up, and he kind of looked at me and mumbled some words, and he was back asleep again. And that's abnormal. People should be able to wake up, unless they were up all night or something unusual happened, or they had a bunch of pain meds, an hour before, and they're not used to that. That's all different. But he had none of that. This was very out of character for him. So what would you do? You'd get a heart rate and blood pressure, do that right away. Check a blood sugar, right? If someone's really low blood sugar, they can be very lethargic and sleepy, so that's real easy. That's within our care as nurses, and even CNAs, right? You can check all that stuff. But then we needed to get a blood gas because we knew he had bad lungs. He's acting like this. Blood sugar was normal, heart rate, blood pressure was normal. Get a blood gas. And that requires respiratory therapy to come in. They do the blood gases because you have to go into an artery, because isn't that where our gases should be, our oxygen should be the highest, right, is in the arterial side, and we don't like to poke into arteries because they're under pressure, right, and they spurt blood. So we need a special person with special training to get those blood gases from the radial artery. So when they did that, his CO2 was really, really high. And because his CO2 was really, really high, his pH was low, and it was affecting nervous system function, and that's why he was so out of it. So what we do is we put a mask on those people. It's called the Bipap Machine, covers their whole face. You know, it creates a suction there around the face so no air can leak, and we change the pressures to draw the CO2 out. So it's hooked up to a machine, and that increases the diffusion and the what's the word called? There's a name for it. Anyway, that's not important. The biggest thing is it helps draw the CO2 out. And then he was better. And that's what some of those people need when they just kind of get in a bad state with their lung function. Voice production, we know that we have vocal cords that vibrate as air flows out of the glottis. It vibrates our vocal cords. Like if you try to talk while you're breathing in, it sounds really strange, right? That's not the way our vocal cords operate. It's when air is flowing out of the glottis. So if a person has a ventilator, a trach, okay, a tracheostomy with some tubing connected to assist their breathing, can they talk? We need air to flow through the glottis to vibrate those vocal cords. If the air is going below, I mean, think of where the tracheostomy is. It's right at the top of your sternum, right between the two starts of the clavicle. That's where that tracheostomy goes. So no, they can't talk. That's the biggest frustration about people that have bad lungs but that are otherwise healthy and able to communicate, is they can't communicate because there's no air flowing through the glottis. So sometimes they'll get a little valve to close that, and then they can talk. But they're not getting the support of the ventilator when they're doing that. So they have to have decent lung function to be able to put a speaking valve on there and be able to talk to you. So that's the biggest challenge. And then you'd think, oh, no big deal, right? If I have a ventilator patient, then I'll just hand him a chalkboard and he can just write what he needs. Well, the reality, you're laughing because you work in this environment, right? The reality is, if you're on a ventilator, what do you think your overall strength and health is? Probably not great, right? So I've done that. I've given a little whiteboard to an old man that's on a ventilator, and he's trying to write, and his hand is shaking, and he can barely hold the chalkboard, and you can barely read what he's saying. So it's really a challenge. Or other people have like congenital neuromuscular disorders, or maybe even acquired ones like Lou Gehrig's disease, ALS. You know, they can't move anything. So then they try to move their lips, and you have to be a really good lip reader. I'm terrible because I'm on call. I show up for a day or two and then I'm gone. I don't have that relationship with those patients, but people that have said, oh yeah, he's been here for a month, I've been taking care of him for a month, every time I come in, I'm assigned to him for 12 hours, those people really know those patients, right? And that's who we want to assign to those patients. But for people that work in the hospital, what's the problem with that? Being assigned to a trach patient every time you work. What do you think about the level of time to spend in the room with a trach patient that can't move versus a person that's in with pneumonia and getting IV antibiotics? A lot of time, very time consuming to have a person with a tracheostomy. So the problem with that is people get overloaded and burnt out, and their healthier patients get neglected because you spend so much time with those patients that have tracheostomies. So think about that. When you have a patient with a tracheostomy, communication is going to be a challenge because they can't talk when that tubing is there. Olfaction, smell. Smell occurs when we have chemicals that absorb into that mucous membrane and stimulate chemoreceptors that travel through, remember the ethmoid plate? Into the cribriform plate, right, of the ethmoid bone to the brain for smell. And protection, we have cilia, mucus, and macrophages that help protect us from infection because the air we breathe is not sterile. There's a lot of fungi and dust mites, a lot of debris, skin cells floating around in the air that we're inhaling every time we breathe. But we have these protective mechanisms to keep our airways healthy. So some terms, like I said, that should not be confused with cellular respiration. Ventilation just means the movement of air in and out. So when we put someone on a ventilator, we're moving air for them. And the pressure, the positive airway pressure that we put into those machines depends on what the patient needs are. Some can breathe on their own, they just need a little help. Some need total support, like people that are, have a traumatic brain injury and maybe will never recover, or an anoxic brain injury. They were in surgery and blood flow was impaired and they lost blood flow to the brain. Sometimes those people never come back, but we say they're in a coma, right? Some people are in induced comas where we just give them lots and lots of medication and knock them out for a period of days, and others are in comas because of, problems, and they may never come out of it, and that's where we make that decision. So we put them on a ventilator in the meantime to decide what we're going to do, and we do the breathing for them because they can't maintain their own airway is what that's called. So we put them on a ventilator for that purpose. Why we would induce a coma in some people is for brain rest. So we'll do that, and for people that are detoxing, because detoxing can be really bad for some people, right? They have seizures and they're delusional and just really goofed up during that period of time. So if we induce them into a coma, we get them through that addicted period or that withdrawal period, and then they come out and they can function a little better. And that's why some people come in for detox, for hospitalization. Some people can't detox at home or even in a rehab center. They have to come into the hospital because they have severe withdrawal. Yes?
When you're referring to induced comas, are you referring to sedation?
Yes. Those are two types. Yes, 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 yes. And I don't see the paralyzed kind because that's a critical care thing. Is in that? All right, so external respiration and internal respiration. The only thing you need to think of is where is the air starting? So with external respiration, it's coming from the outside air into the lungs and moving to the blood. So it's coming in from the outside to the blood. Internal respiration, those gases are already in the body and they're going from the blood to the tissues. So we're just going to the next level. So we're bringing it from the air into the lungs to the blood, external respiration. Internal is going from the blood to the tissues. And then we already talked about the function of transporting the carbon dioxide and oxygen through the blood, right? So a little more description there underneath. You can read that on your own. So when you divide the respiratory tract, there's the upper and the lower. The lower respiratory tract starts with the larynx. So if you go into the doctor and they're like, oh, you've got a really bad cold, yeah, I'm coughing up all this junk, I'm going to say, well, your lungs are clear. And you wonder, how is that possible, right? You feel all this junk coming up. Well, that's because it's in your bronchi. We studied in lab the first and secondary, tertiary bronchi. That's where the junk is, but it's not in your lungs. So that's a good thing. You don't want to have fluid in your lungs. That's pneumonia. And it's a small percentage of people that have a cold that end up with pneumonia, but it does happen. So upper respiratory infection is from the throat upward. So when you have a drippy, watery nose and you have that, the uvula is kind of swollen and tender every time you swallow, that's an upper respiratory infection. And that can become a lower respiratory infection. Because what I do is when I get that really watery, drippy nose cold, I take a medicine that is an antihistamine that dries up that mucus right away. Because if you take care of it in those early days, you don't produce as much mucus. And if you don't produce as much mucus, that's less that'll settle down into your bronchioles and create a nasty cough for a long time. So that's one way to help your cold be a little shorter and not have a cough, is to control mucus production early on in your cold. Mm-hmm. Yep. And the one that you can't take, like Zyrtec and Claritin, that doesn't work. That's more of a allergy antihistamine. The one for a snotty nose cold, there's a number of. Okay, so our first upper respiratory structure we're going to talk about is the nose. We talked about this in lab, so I'm not going to go through all the structures of the nose, but we're going to talk about functions of the nose. It cleans the air. The cilia in the nasal cavity cleans the air. The mucus is mostly water and a little bit of that slimy stuff, right? That humidifies, so it adds moisture to the air we bring in, and the capillaries that are near the surface of the mucous membrane, that warms the air. So by the time that air is inhaled into the lungs, it's warm and moist. So when we are bagging somebody and putting the big balloon thing that we squeeze right to the tracheostomy, we are really putting dry air in there. So that's not something we want to do long term, right? We'll eventually hook them up and put a little humidifying box of water on there to moisten that air. Smell, we already talked about that, and resonating chambers for speech. Our sinuses, when our sinuses are clear and functioning properly, our voice sounds normal, right? But if someone has a really snotty, wet cold, they have extra resonation, right? You can hear, like whenever I talk to relatives over the phone that I don't see very often, I can tell if they have a cold because they have that real resonating, that real clear sound when they have a snotty, wet cold. And then if they have a sinus infection, they have a real thick, kind of non-resonating sound to their voice. So that's the benefit of those sinuses. The larynx is our voice box, we know that, and that maintains an open airway. So when we're sleeping at night, we can still breathe because the cartilages of the larynx are held open and the vocal cords pass through there, stretch across. And when you get a cold and that mucus is running down the airways and it starts to kind of inflame the vocal cords. If you have a virus, it causes inflammation of the vocal cords and people can lose their voice. Very, very important if a person loses their voice with a cold to not talk, and whispering is worse. Whispering strains the vocal cords when a person has a respiratory, and I'm an expert on this topic because I had laryngitis probably 20 times in my life, and I think it's from teaching. When I get a cold, I get laryngitis, and I've had to teach like with no voice off of transparencies or through my phone doing the voice texting because you can't miss class and I always get at the end of the semester, so knock on wood that doesn't happen. But that's what I've learned. I've done a lot of research on what not to do to get your voice to come back. You have to rest your voice if you have laryngitis. Whispering is terrible. Alcohol is terrible because it dehydrates and makes the vocal cords worse. So saltwater rinses and resting the voice is what you have to do. I even picked up some patients. I was supposed to work one time and I had no voice. I'm like, you can't be a nurse and not talk to your patient, right? So I said, yeah, I'm willing to work. I feel good, but my voice is gone. So they assigned me to a patient that was dying and just needed titration of his pump to keep him comfortable. He was dying. He didn't want any more dialysis, and he just wanted to die. So I was in charge of him and just keeping him comfortable, and he did not want to interact. He just wanted to be let go from his kidney failure. So I just kept him comfortable and worked a full shift. So sometimes you don't need your voice for some patients. So we talked about the Valsalva Maneuver in the past. When we close the glottis, that means when we close that hole. Remember, the glottis is that space between the vocal cords. When we put our vocal cords together and then we try to force air out, that pressure goes downward instead of upward, and that's the Valsalva Maneuver. That increases abdominal pressure, and that's what women have to do to deliver their babies to help, unless that baby is coming fast and furious, of which most babies don't come that way, but some do if they're lucky, or maybe unlucky. One of our math instructors here, he had his baby, his wife had his baby in the van coming where the Dresbach exit is. He had his baby on the side of the road there. So that baby came fast and furious. Anyway, so when we close that, that lowers the heart rate, stimulates the vagus nerve, so that's good for a person with a really high heart rate. We talked about very dangerous in people with a really low heart rate. And it's a reflexive maneuver that we see happen during a bowel movement. And if you have young children and you're standing in the stall and you have to be part of that experience all the time when they're 2, 3, and 4 years old, you can witness that reflex happen because it's just an automatic reflex as people move their bowels. The trachea, that's our airway below the larynx. Remember, it ends in the carina. That gives us that violent cough reflex at the bottom of the trachea before it divides into the bronchi. There's C-shaped cartilage that lines the trachea, keeping it open. Behind the trachea is the esophagus, so we can see that here. So that's why there's no cartilage here. So when that esophagus enlarges with a bolus of food, it can expand into the trachea. So the bronchial tree is the branching of the right and left bronchi. Then we have the secondary bronchi, the tertiary bronchi that serves all the bronchopulmonary segments. But that branches, like we said, 21 more times before it gets down into the bronchioles and then into the alveoli. So the conducting zone is going from the larynx all the way down to the bronchi, or the bronchi. So there's pseudostratified columnar epithelium, there's our ciliated cells, there's mucus, there's cartilage, there's some smooth muscle. But when we get down into the bronchioles, that very last branch before we get to the alveolar duct, there's no cartilage. There's increasing smooth muscle to keep those airways open. Very little cilia, little to no mucus, but we have these immune cells, macrophages, that take over and they act like little Pac-Men and they eat up the debris in the lower airways. So this is where it gets dangerous though, right? We talked about people with allergies, that smooth muscle will constrict and prevent gas exchange, or prevent airflow, and that prevents gas exchange. So we'll pick up in the next video talking about the alveoli as part of the respiratory zone.